So for this segment, what we're going to be kind of starting to veer into a little bit, we've been talking a little more programmatically, then kind of introducing, the overall file structure and some of the file issues that come up there, and we're going to veer a little bit more into some of the data quality concerns and those kinds of things that are going to come up with trying to apply TAF. These are not necessarily not all of these are necessarily unique to TAF. Some are, but they're not necessarily unique to TAF. Some may be fairly generally applicable to a lot of administrative data sources. Some are similar to what you might have found in MAX. Some are to a lesser degree found than what you found in MAX. That is the previous version of the Medicaid research files. But it's again, these are the kinds of things that as we were originally putting this together, we were looking at assistance requests from the logs from our internal systems. We were talking about things that we've had people, researchers ask about, and certainly things that we've run into ourselves, as well as things that maybe make this, the TAF data source a little bit different from what we think of as kind of a baseline for administrative claims data, which is kind of the fee-for-service Medicare is kind of the thing that a lot of people are used to. It's one that is fairly stable in terms of policy changes and other things. Doesn't have some of the state variation and so on. So sometimes, at least internally, we think of that as kind of a starting point. So when you start thinking about, well, how are the TAF data different from something like that, like a fee-for-service Medicare? What things pop out? Again, as well as assistance requests and other things we've gotten from researchers. So I'm going to go ahead and share. Should have this ready to go. So this is segment 4. And there we go. I think this might have been in segment 2, but if we want to think about the importance of research using TAF data, you can think of states, if not the whole country, as kind of a number of different health policy laboratories that are all operating. And so there are a lot of potential opportunities in terms of natural experiments and difference and so on that you could approach those states with. But another way to think about this is that vulnerable or marginalized or underserved populations are sometimes reached, not always reached, but sometimes often reached by Medicaid. And so if we're interested in improving services for individuals in a number of different populations, research using TAF data can try to aim toward that. And also just researcher use, and this is part of why I think CMS originally was interested in kind of widening files out a long time ago, widening files out to a lot of researchers for use in research, is that researcher use contributes to improvements in the data. That improvement cycle may or may not be slow. As I mentioned, I think that the transformation effort for TAF itself is actually pretty impressive. Yeah, so I think you can kind of consider this to be, potentially beneficial in a number of ways. So we got a lot of common issues that again, these are not necessarily at all unique to TAF. We've got missing data and incomplete data, and that could be at the enrollee level. It could be at the field level, the variable level. The values in a particular field. So another data quality aspect is like implausible values, consistency of values and data entry and those kinds of things. Whether things have been or can be validated against at least some benchmarks, if not an actual linked validation set somewhere. Other issues that are a little bit more, certainly more common to Medicaid, if not just TAF only, include things like frequent disenrollment or churn on and off. And of course, as we've mentioned, not all Medicaid expenditures get captured. And there are a number of things we've mentioned, for instance, payment information on the managed care encounter records, but that's just one thing. So there are a few things that may not be captured, which are a little more specific to TAF. So examples could be missing, examples that we've seen plenty include missing eligibility code, which again, as I mentioned, it's kind of important to understand what eligibility group a person's a part of in order to kind of determine your cohort and whether they belong in it. But sometimes people will definitely have missing eligibility codes. There may be eligibility categories, especially eligibility categories that have no cases in them for a particular analytic cut. You may have missing demographic information. So things that we would consider to be fairly, I'm trained as a sociologist, and variables that you're used to seeing in data sets. Again, these would usually be data sets that are designed for research, like surveys, but things that you would be used to seeing as very just common things that you use in a model, like race or ethnicity. Those things are missing to a not tiny degree in TAF data, as well as a number of other data sources, of course. So missing demographic information, or maybe you've got some demographic categories with nobody in. So again, you get this idea of you've got a person with missing information about them, or you have a category that's actually missing people. Utilization, you may have what seem to be, again, this kind of goes back to what I consider to be kind of the category of implausible values, but very, very low numbers of encounter records for managed care organizations. And we're going to get to these, so I don't want to get into defining each of these right away, but just listing examples. Payments under waiver in a state that's not using that waiver. Or maybe you've got a waiver and there's no payments. And obviously, as we mentioned, missing provider number or type. I can, like, one example that comes to mind is in looking at, it was a managed care paid population, some of it in an accountable care organization, some in other managed care plans. One of the things we were interested in was coordination, care coordination. And so one of the ways to measure that is looking at, are people seeing the same providers all the time? And what we found in that case, and I'm not saying this is true of all cases, but what we found in that case is that individual, and we actually answered a question about this just a bit ago, the individual provider number, the individual NPI for the provider was not there all the time, and in fact was missing quite a bit. And so that meant that tracking people across providers, which is what we really wanted to do, we couldn't really do that to any kind of a comprehensive degree. And the trade-off would have meant, okay, we can run this analysis, but only on this subset of people where the provider NPI isn't missing. Alternatively, what was available was like institutional NPIs, so we could track. And this may be, we certainly see this in the literature, but you may see where care coordination is measured, are people staying within the same, say, health system, or same hospital or something, and that's all we could have done to a more comprehensive degree in that sample. So you do run into these, and I'm sure that if we open it up to people who have used these types of data regularly, you could list a lot of these kinds of things, where it's a data quality issue, and if you're really into being a data nerd and defining data quality problems, that's interesting enough on its own, but what it really does is it complicates our ability to develop inference, to draw conclusions, those kinds of things. And if you're interested in the practical implications of your work, which hopefully we are, those are real concerns. So it's not just a methods nerd issue. It does impact what we can do in relation to the real world. So there are a lot of different things that can go into this, and this is where thinking about state Medicaid programs and so on, and how they can vary, adds wrinkles to those things. So it's one thing to say, well, you're going to see some disenrollment, or you're going to be missing some values, but how that plays out is shaped by a lot of different factors. Again, some of them pretty common across a lot of data sources, and some that are a little bit more specific to Medicaid and TAF. So program design effects that you would see in the data, other than maybe some mandatory groups, states do have flexibility in defining eligibility. So outside of kind of required groups, there is going to be state flexibility. And because there's flexibility in eligible groups or eligible individuals, then what you need to do is understand that as you are selecting for a particular set of groups for your analytic sample or your cohort, or assign, if you're assigning basis of eligibility to help define people, those kinds of things. We need to kind of take that state information into account. That's a contextual piece of information that often you may see some indications of it by looking descriptively at particular fields in the data, but there's not necessarily something in the data that will tell you exactly what's happening on a policy front or on a state administrative front, those kinds of things. And so we kind of have to be aware of those things, be looking for those things, and then figure out how we're going to build that into the design of our analytic sample or cohort. There's also flexibility not only in eligibility, but of course in program design. So obviously there's the use of managed care, which, as we've seen, at the very least is going to lead to certain fields being redacted if it's an encounter record versus a fee-for-service claim. And that may play out for some eligibility groups in a state or all eligibility groups in a state. It may be that managed care is covered for some versus all services. So we've got comprehensive managed care versus dental only. Comprehensive managed care plus dental versus dental only. Or you could imagine behavioral health or some of the other categories that you might see for managed care. And again, you may be comparing that to comprehensive versus a behavioral health or dental type model. So restricted benefits versus more comprehensive benefits, and how that shows up, then what that will do to what the data look like. And then billing and payments for the fee-for-service model. So again, we've got those kinds of we got that kind of information for the fee-for-service, but then within fee-for-service itself, we need to know what the basis of payment is for, and again, what different aspects of what a state is doing or what states are doing in order to really understand what's happening in the fee-for-service. That's, again, keeping in mind that payment information in managed care isn't there. So a lot of state decisions that are then going to influence what we're trying to do, which is often at least at a multi-state level. I don't necessarily see a ton of like fully national studies all the time, but certainly in a multi-state level, or if we're trying to create a comparison group of states or other things. Variations in eligibility definitions. So again, we've got this state flexibility, and so in the DE file, which we've mentioned, eligibility group codes, they might not be used in every state or in every year for the same state. So an example here would be if we're looking at eligibility group code, and and remember that you can have potentially multiple of those, the number of states with at least some beneficiaries in those codes varies. It's not 51 in every case. It's not all states in DC. So extended Medicaid due to earnings, extended Medicaid due to spousal earnings, some of these kinds of things where people are receiving Medicaid, and if we're interested in the Medicaid program, presumably we don't want to drop them, but that doesn't necessarily occur across states. And more directly for what we're talking about here today, it doesn't necessarily play out in the data across all states. So again, if we are searching for particular codes and so on, and we're using that as the basis for selecting people, we're going to need to think about the implications of applying the restriction for, or a requirement of a particular code to be, say, in your analytic file, and what that does to some of the other categories that may not be common across all states, as an example. You can have a number of different eligibility codes that might be used, and so this is why we end up with these kind of larger. And I think we showed a version of this earlier. This particular tables from MacPack. This is why you end up with kind of as you're trying to put together a group. You probably need to kind of figure out the right combination of eligibility codes, age groups, and so on to kind of bring them down into what might be a theoretically or analytically a theoretically or analytically useful group for you. And so we just want to kind of, again, keep in mind that usually it's not going to be one code or two codes or one rule. It's usually an algorithm, a multi-rule approach, or a rule set approach in an algorithm, as opposed to kind of a very simple way of saying it. And this is why, also why sometimes in answering a question, there may be a lot of kind of conditionals that we would give, or say, well, depending on the state or depending on the waiver or whatever it is. This, again, we just get a lot of this variation, and how that plays out in how we use particular fields to create our categories of interest is not a non-issue. Managed care data and quality. I had a question come up in the chat about this. This is just kind of a way of visualizing it. So again, keep in mind, we kind of mentioned this, but fee for service, the way I think of it is a direct link, or one way of understanding this is that in I should say the figure is representing a managed care path, but in fee for service, that middleman of the payer MCO isn't necessarily there, right? So you've got a claim that's submitted, and at least in Medicare, for instance, to provide an example, in Medicare, that claim gets submitted to a Medicare administrative contractor. It's called a MAC, which are set up regionally throughout the U.S. And the Medicare administrative contractor, it's representing Medicare. It's not a managed care plan. It's not an insurance plan. It's doing Medicare's work. It's just a contractor doing the work. And then beyond that MAC, you have a common working file host site, which is the next level of processing, which then will kind of feed or dump information from that administrative process, that is the payment of bills and determination of eligibility, and those things that happen on the payment of bills, will dump that information into the internal CMS repositories. That's on the Medicare side. But to provide an example of like that direct link, it goes straight from a provider to a MAC, and the MAC is a representative essentially, or doing the work of the Medicare program. So when you've got that fee for service, I kind of feel like, again, I kind of think of that as a little bit more of a literal or direct link between the provider and the services that are billed and what the program sees. In contrast, we get this process that's represented by this pictorial here, where you've got a provider, they submit a claim. So most of the time they are submitting, you may have some other kinds of arrangements, but you can imagine the idea of a provider submitting a claim on a fee-for-service basis within that arrangement to a payer managed care organization. And the managed care organization in some ways is helping to administer the Medicaid program or the Medicare program. But what it is actually a private insurer. So, I don't know around where you live, but around the Twin Cities here in Minnesota, I will regularly see billboards up for a private insurance company that is advertising its Medicare managed care plans, for instance. And so you'll have a private organization that is administering an insurance plan. It's just that it's financed in some way, usually by the Medicare or the Medicaid program. And so what happens is you end up with kind of this extra step in the processing. And so we kind of mentioned this already, but the idea that you might have a claim that's submitted, but it gets submitted to an MCO as opposed to being submitted directly to Medicaid. And then the MCO reassembles the data. You could guess that it's kind of a bit of a roll-up into an encounter record, which is not the same thing as a claim. And so at least potentially, this may raise questions about the completeness or quality of the data for people where we've used fee-for-service data for a long time, but more directly, I think, fee-for-service data kind of allow us to parse through the bills that are submitted, the claims that are submitted, and they're very kind of literal representation of the services that are being billed for. So we can kind of parse through that because they end up in the data in a form that's somewhat similar to that. Meanwhile, the reassembled encounter data records that end up in this case, the TAF, there's a little bit of transformation that happens there, and we don't necessarily, we're not privy to it from the research file side very much, and so there's at least a question as to what does this do to data quality? And we had some questions in the chat about, what if we look at differences in utilization? For instance, if we estimate, are there differences in the estimated utilization between managed care and fee-for-service? And that's one way to look at it. The issue is that if there is a difference, we don't necessarily know whether it's because of a data quality difference or a data completeness difference, or just a difference in the actual utilization rates. And so you could try to do things to limit that. You could limit it to acute utilization, inpatient stays or something, and and so on. But there's at least a question. Now, what I would say is that there are a few things that lead me to have more confidence than I used to about this link. One of them is that states can audit or incentivize or support or sanction MCO plans, right? So on the data creation, on the process of data creation side, states can do those things. CMS has also provided guidance and support, which I believe was I think fairly increasingly bolstered under the TAF kind of transformation effort. But if this is something you want to think about, it's also relevant then to think about the fact that managed care is very, very, very common in Medicaid. It is a very large share of Medicaid. And so if this is a question you're asking, if it's something you'd look at, it's worth remembering that it's a question that has, broad implications, even if those implications turn out to be not much. And comprehensive managed care enrollment is very, very common. We showed this before, but just keep in mind that the majority of enrollees, if you're looking across these states, anything that's blue or lighter or darker blue is 50% or more in comprehensive MCOs. So it is just a big part of Medicaid. And so again, if we think it's a source of concern, and I'm not necessarily saying it is, and I say I've become more confident in the data over time, it is a large share of Medicaid. But even without managed care, we've got variations in payments to providers that could be due to a number of factors. They're going to influence how we measure services on the claims. So states do have discretion over the payment design. We do have fee for service, but there also may be per day, per visit, or per encounter payments. So beyond just the encounter records, we've got other types of arrangements. Or you may have bundling payments, bundling of payments. So you may have bundling of prenatal care with labor and delivery. Those kinds of things. So it's not necessarily, even without managed care, it's not necessarily going to be a true kind of fee for service. Every service gets a claim or claim line kind of arrangement. And again, that's going to vary by state and over time. So variation in the basis for inpatient hospital payments. We actually had somebody asking about DRGs, for example, I think in one of the previous segments. DRGs, which if you're familiar with Medicare, are obviously incredibly important for inpatient payments. They're not necessarily the basis for inpatient hospital payments for all states. So again, we got per day, cost-based, other arrangements that might be there for inpatient hospital payments. But again, there also may be differences in separate billing for the professional services that go along with this. So this is one of the things that we talk about when we look at inpatient services. Just because there's an institutional claim for an inpatient stay, that doesn't mean that all the information that's relevant to what happened in that stay is going to appear just in the inpatient file. There may be professional services that show up. Now, on the Medicare side, that's in the carrier file. If it's a physician type payment, or a provider type payment, a non-institutional provider type payment. So if there's some separate payment that may be derived from that, it may show up in the carrier file and the Medicare files. But here, right, we've got inpatient, and then we've got other therapy, which compared to the carrier file, which is itself kind of a monster, the other therapy file is a big complex monster of a file. And so if we've got the separate billing for professional services that might show up, that's going to show up there. And then, of course, we've got all these other things like dish payments and so on. So there's just a lot of sources of variation in how things get paid for and what services get paid for where, and those kinds of things. So again, unfortunately, we can't say there's this one approach that you can take, and that will get you all the answers that you need to design your analysis. It's probably going to depend on the types of services you're looking at, the states that you're looking at, the eligibility groups you're looking at, and so on. And that's where a lot of these other resources become really, really important. So lists of waivers, payment, we've got MacPack resources there, for instance. A lot of those things are going to be the kind of homework you need to do, or the kinds of sources that will inform what is actually written in code as you develop not only your denominator for your analytic file, but your analytic file broadly. The federal-state partnership, I'm trying to think if there's much that gets added here. States may make changes. Yeah, so I think this is mostly a reiteration, with keeping in mind that there are some federal requirements, and then there are lots of state variations that happen within that, both in terms of what states cover, who they cover, but also how states submit their data, and the state, data quality and so on, data submissions and so on. Those also vary by state, which we'll look at in just a second. So we not only need to think about what policies are shaping our what happens in our states for different eligibility populations at different times, but we also need to be very cognizant of how the data quality, data completeness, and so on also differ by states. We had a lot of questions about the NDI in the last segment. I mean, there are certain years where the NDI just doesn't include certain states. So again, because of a data completeness and a data submission issue, that just happens. And so we also need to be very, very aware of that and build that into our design very intentionally. Some of these slides, I'm going to get into some data quality issues that we'll be talking about a little bit more after this. So just keeping in mind, the opportunity here is that T-MSIS really enhances what we can see in the program. And it really helps researchers do a lot more comparative state analysis, if not national. But there's also a challenge because it is a very complex system. You've got a lot of data streams feeding into this. You've got a lot of different types of players and different players. And then, of course, again, you got state variation in all of that. So this is multiple interacting factors, which is one of the kind of core defining features of a complex system. And data quality is not just at a beneficiary level. We'll see this in just a second. So this comes from the DQ Atlas. Now, I believe we'll be talking about this in another segment, the DQ Atlas more broadly in another segment, but I want you to just draw your attention. This is from the Data Quality Atlas, which if you're doing this research and you haven't started looking at this, you should start looking at this. The Data Quality Atlas, it's at Medicaid.gov, has done a lot of different benchmarking and data quality checks and other things for different types of variables, not necessarily all fields, but a lot of the fields that would be really important. And so starting at green into yellow, you might be okay using the data, but then red here indicates what is classified as unusable. That is a percent of beneficiaries with missing values, in this case on family income, and that's greater than 50% for those red states. So if you're trying to get family income information, that would be one thing where you've already got a concern. Similar idea here is, again, red is unusable, but even orange is a high concern. And here we're looking at race. As I mentioned, race seems like it's kind of like one of those core demographic variables, let alone that it's perhaps better understood as a proxy for systemic racism or bias. But we tend to think of it as one of the very common things we look at in data files and data extractions. Well, a number of states here are at least of high concern, and that is percent of beneficiaries with a missing race ethnicity of almost 30%. So if you're going to try to use it, again, if you're not imputing or something like that, list-wise deletion would lead you to drop those folks. And similarly, we've got plan encounters with for inpatient. There are a number of different criteria here, but this is looking at inpatient and whether there are implausible values and a number of other potential data quality or completeness issues. This is for inpatient encounters. And we still see some states at least of medium, if not high concern. So we have to pay attention to these as we select states and move forward. And again, I don't want to belabor these because we will be talking about them more. So the data missingness and data quality concern takeaways, some data will be missing that is at potentially the beneficiary level because of disenrollment. It may be at the field or variable level. It may be at a state level in some cases, possibly. And so there are a lot of levels where that missing can play out, and it may play out on a monthly, annual, or otherwise basis. Some data will need are going to need interpretation. So if we're using very, very, very low levels of utilization, is that a state data collection, data submission issue? Is it because that state has a pretty tough set of barriers to obtaining health insurance or to obtaining services under that? You know, those kinds of things. The data don't tell you that, so that's again a judgment call, a judgment you need to make, and it's not again readily available in the data. And some data will not make administrative sense. So we do have some data runs looking at service use after death. They do tend to be rare, and that's true of a lot of these things that make no administrative sense. I've often said I kind of got a general rule that, you know, somewhere between 2 and 5%, about 3%. Of just about any field seems to make very little sense. So you're going to sometimes run into that. And then the question is, what are you going to do about it? How much time are you going to spend on a relatively small percentage? And then just to provide one example is the issue of disenrollment. So this is a common data cleaning step that people take. So if we assume that people should be just kind of enrolled for a long period of continuous time, there may be a reason why you do this theoretically, because you want people to have the full dose of the Medicaid program. They should be enrolled for at least a certain period of time. You may need sufficient data to capture events, and you may actually be using it as a predictor outcome too. I mean, disenrollment itself may be of empirical interest to you. But Medicaid's got an added wrinkle because, of course, churn or change in coverage is very common in Medicaid. And most often, if people are dropping off of Medicaid, or very often, I believe around half the time or more, I've seen a couple of different reports at different times, but very often people are dropping off of Medicaid in no coverage. But it could represent onto marketplace or new employment or something like that as well, of course. Again, we don't know that from the data. In addition, you got variations in program administration. We do have retroactive coverage. And if you compare this to like Medicare, it's very, very different because we're just not used to seeing this. And I should say that continuous enrollment is less of a problem I've noticed among, for instance, like long-term care populations, or at least some of them. So this also varies within populations in Medicaid. But, you know, think about all the kinds of patterns, and I have seen all kinds of patterns of enrollment. I've seen 1 month on, 1 month off, 1 month on, 1 month off, 2 months on, 2 months off, all kinds of variations, even when plan administrators have told me, no, our default period is 6 months. That's just not how it has shown up in the administrative data, at least not always. So one thing that I wanted to note here is that researchers very often, and I believe most often, just drop these people, or they don't include them in the analytic sample. These are just quotes that I've taken from different studies, and I'm not faulting anybody for doing this. I just want to note that it's very, very common. This is a very common approach, is dropping people as a criterion, requiring continuous enrollment of usually 6 months, sometimes 12. It's just very, very common, and I believe the most common approach that I've seen. Again, not faulting anybody saying that that's wrong. It's a trade-off. But there are a lot of considerations, and if we're going to look at continuous enrollment. So we're looking at enrollment days. We have monthly codes, right? So even as you look at this, you need to make a determination on what you're trying to do with what variables. Are you going to use these kinds of days versus months, monthly indicators, and so on? And then whether you're looking at managed care enrollment as well, and whether that counts. Again, that's going to depend. But if we're just looking at overall enrollment, we can kind of think about this kind of monthly on-off pattern at the very least. So this is just an example, but in map form. But if we were to take continuous enrollment as a requirement, where we're requiring beneficiaries to be enrolled at least 6 months to stay in a sample, or if we're looking at that as a variable, up to 20% of people are lost in some states just because of the application of that continuous enrollment criterion, with at least 6% in some other states. And that, of course, is only amplified when you're looking at 12 months continuous coverage and so on. Now, I would note that the percentages, you should not use these particular percentages as the basis for a factoid in your brain, because depending on how you start your denominator, these percentages will be higher or lower. So these percentages are especially this 53% is relatively high. Depending on how you set your denominator, it may be more like a third or 40% or something. So I wouldn't just use that as a benchmark, but the idea is that you can lose up to a third to even a half of your analytic sample, depending on how you've defined your denominator, just by requiring 12 months of continuous enrollment. That's without any other potential loss. And of course, this doesn't play out the same across all groups. Age here is just one example. And we can see that, for instance, very young adults have a really low percentage remaining in the sample after we apply that kind of criterion, for example, whereas other age groups are different. You can also think about eligibility groups, really different. Whether you're talking about a birth parent or caregiver versus somebody with a disability, really, really different loss based on the application of a continuous enrollment criterion. We can also think about what are we going to do depending on where the missing is coming from. So somebody may not be enrolled for all months, but maybe that's because they became newly enrolled. They were enrolled after the beginning of the observation period. So maybe that's an example where we see like 13 or 14%. In this case, we were talking about 2019, where they became newly enrolled possibly. Now, I mean, if you added another year, maybe you'd find that they had been disenrolled in the previous year, but at least for this year, it's a left censored issue. Or you got a right censored issue. Possibly they died, which you may or may not be able to tell, as we noted with, there are some potential issues with the NDI and so on, and death dates. But maybe they became ineligible. Maybe their enrollment was allowed to lapse. And again, the factors that lead to that are probably going to vary by state. Or maybe you've got a mixture of disenrollment and re-enrollment. Maybe you got both. Maybe you have a non-monotonic missing pattern where people are popping in and out with a lot of churn. So exactly what we do with those, if we're using them to define a cohort, if we're using them to keep in the data, if we're using, if we're making decisions on imputation, what we're going to do in each of those situations actually does kind of matter for this, not only the size of our analytic sample, but the shape of it. Because as we said, it varies across age groups, eligibility groups, and so on. That means that we're actually going to change the shape, not just the number of people in our sample, people and groups in our sample, by applying different rules as to either include or exclude or impute or so on. And of course, there are a lot of different possible approaches. Obviously, you can remove people, and that does happen. But approaches we've used, I've used censoring weights instead, so that we can apply those weights on a time varying basis. You could try a sensitivity analysis or pattern mixture approach where you kind of try to impute plausible values. You can try to use broader imputation methods, right? But most of these rely on at least observed data, or they rely on your assumptions to inform or adjust or impute what are otherwise unobserved patterns. And this is where the issue of disenrollment and the broader issue of missing data leaves us. It's just that in TAF and in Medicaid, disenrollment is not a small issue. And so we probably have to face this in some way, with the realization that letting those people drop who don't have complete claims is also a choice. It is not a default, it is a choice itself. So with that in mind, we just remember that disenrollment is one example, but it's one example where it's not a variable or a field that's missing. It's actually censoring people out of the people at people level out of the data. We could hope that retroactive coverage helps with this, but we don't really know. Censoring can also create bias demographically because it doesn't hit groups equally. And we can get very fancy statistically, but it's going to still rely on a lot of assumptions and things like that. So again, just requires a very careful approach. So again, we have to shy away from one size fits all. We don't have a lot of easy answers. We recommend due diligence and a lot of homework from other sources. And really try to understand make a good faith effort at understanding where the potential issues are, and maybe running sensitivity analyses or other things to try to explore that. Yeah, so anyway, just wanted to highlight all those. And then again, I want to highlight the Medicaid Data Learning Network to just mention that some of the more in-depth issues that you can run into are the kinds of things that I believe a group like that would probably be really prone to address. But whether it's that group or some other group, I do think it's also really important to pay attention to how have other people addressed this problem. Not to say that we take everything just readily the way that somebody else did it, but rather I've seen some pretty creative ways of using the data, and I've tried to be creative in how I use the data to address different problems. And so I think learning from other people can be a really valuable way to do that.